Currently a practicing IVF expert at New Delhi, and I've done my training from All India Institute, New Delhi, and then moved on to Guy's and St. Thomas, UK to do my training in IVF. Currently, I'm practicing as an IVF expert in the city for the past 5 years. So my topic is very interesting. It's whether we should convert IVF into IUI in poor responders or not. And this has always been a question amongst us, and it has varied depending on clinic and doctor practice. And I think a little bit of study into it has given rise to quite clear choices that need to be made. Now, this is IUI conversion in poor responders. So firstly, we need to be very clear of what poor response is all about. As we all know, ovarian stimulation is a key part in IVF, where we are trying to compensate for the inefficiencies of the process. Now, it is present in various studies, poor response, anywhere between 9 to 25% of all the IVF cycles. There are various reasons for it, we all know it, and there are various hypotheses. There could be reduced FSH receptors in the granulosa cells, there could be antibodies, there could be blood flow problems. So the theories go on and on. Again, there are predictors for poor ovarian response, and they are static, dynamic, and ultrasonographic. Static AMH is coming out in a big way, and the current studies have compared AMH with antral follicle count and AMH with day 1, day 2 FSH and E2, and have shown very good correlation with poor ovarian response. The advantages of AMH is that it can be done any time in the menstrual cycle. It is not related to what stimulation the patient is undergoing. Again, there are dynamic markers which are not so much into clinical practice, and ultrasonography, antral follicle count still ranks one of the best as compared to ovarian stromal flow or even ovarian volume. Now, pure response, I'm just going into this to highlight we need to understand what is poor response, pick and choose the patients, and then decide whether we need to go ahead with IUI or convert them to IVF. 2011, there was an ESHRE consensus, and in that poor response, they have made it very clear. Poor response to stimulation, the first criteria has to be that the patient has to undergo at least one cycle of ovarian response, ovarian stimulation. And in that, you have to have at least an advanced maternal age or any other risk factor, for example, premature ovarian failure. A previous poor response, which is less than 3 oocytes retrieved in a conventional protocol, or an abnormal AMH ovarian reserve test in the form of antral follicle count or AMH. So going back to it again, at least 2 of these 3 criteria has to be there to identify a patient as having a poor response. And they have made one stimulated cycle kind of mandatory to fit these patients in. Because at the end, finally, it is how is the patient responding to stimulation. You can have many tests you can predict, but the final test is how she's responding to the stimulation. There is something called the expected poor responder, which most of us are trying to say by the means of their age and the reduced ovarian response test. So with AMH, AFC, age, we are categorizing the expected poor responder, and finally the person with the poor response is the one who is getting less than 3 oocytes in a conventional stimulated protocol. Now, there are various ways and means to manage poor responders, and as we all know, we still don't have a consensus, we still don't have the answers. One of it is, should we convert the poor responder to an IUI cycle to make the best benefit of that particular cycle? Now, why would you want to convert it to IUI? There are various reasons, and before I go into that, who would be that category of patient who is selected for IUI? Definitely at least one tube has to be patent, and the post-was sperm count has to be at least more than 5 million with 50% motile. So this is a group of our IVF patients who have not responded well. We've got less than 3 follicles at the end of stimulation. One of the tube is patent. The sperm count is reasonably good. So now comes the decision, do we convert into IUI or do we go ahead with IVF? The reasons for converting into IUI could be that it's a less expensive option. Perhaps there are similar pregnancy rate in this age group or in this category of patients, whether we do IVF or IUI. And perhaps we can utilize the information we have got in this cycle to optimize the next cycle. So these are the various rationale we can use to convert IVF to IUI. Now, what does the literature say? There have been a few studies, but as is most in this field, there are many which are not long-term, they're not randomized, they're not prospective. So most of them are retrospective. And again, the category of patients chosen as poor responders have varied quite significantly in all these study groups. But few have shown that yes, it is quite worthwhile to convert to IUI. Now, this was a study in 2003 where they have found that the pregnancy rate in the IUI is comparable, which is between 12.5 and again 12.5 for IVF. So Simon Wood finally concluded that patients who respond poorly to controlled hyperstimulation for IVF would not be disadvantaged in achieving a pregnancy by offering them conversion to the medically and financially less interventional IUI. This was a similar study again in 2003, but the denominator of the patients who had finally undergone IUI was less than 80 in most of them, so it was not a highly powered study. Again, this study concluded, agreeing it being a retrospective study, that the option should be considered in the management of low responders, especially those not stimulated with high doses of gonadotropin. This was an understatement that they had made. Now, what were the drawbacks of these studies? They had a low sample size. There was no adjustment made for age or follicle number in the groups that have been converted to IUI or IVF, pregnancy, not pregnancy. And again, they did not limit to one cycle. They took cumulative cycles. Some took over 2 cycles, some 6 cycles. So there's a lot of heterogeneity in these studies for us to draw a very clear conclusion. Now, this was one of the very good studies which I found, and again the sample size was very large. It was retrospective. There were 269 IUI conversions from IVF and 167 who went on to IVF. The group that they considered was less than 3 oocytes, follicles that was there on the day of HCG trigger of the follicle measuring more than 17 mm. So less than 3 follicles, then they categorized into who underwent the IUI and who underwent straight away to oocyte retrieval. If you look at this graph carefully, this is where only 1 follicle was there. This is 2, 3, and 4. So the denominator was 4 and less of the follicles on the day of HCG. Interestingly, the one who had just a single follicle, they did not see any pregnancy. One with 2 follicles, they saw 2% pregnancy rate to IUI and 6% in IVF. The one with 3 saw a 7% IUI pregnancy rate and a 20% IVF pregnancy rate, and the one with 4, a significant difference between the IUI and IVF conversion. So they very clearly concluded that among women demonstrating a poor ovarian response to gonadotropins, proceeding with planned ART resulted in significantly higher pregnancy rates than converting these cycles to IUI. There was very recently another large study, very recently as 2011, in which there were 800 candidates who had converted to routine egg retrieval and 247 continued with IUI, and another group which did not do anything in that cycle. The criteria of this study was 2 or less follicles on the day of HCG. And when they compared the pregnancy rate in the IVF group, it was 6.8, and in the IUI group, it was 2%. So again, there was a significant difference. They then divided the study into those with a single follicle and those with 2 follicles. And again, there was a significant difference in the ongoing pregnancy rate, 7.6 and 1.6. They noted a significant difference that those who had abandoned and then the information achieved in that cycle was used for a subsequent cycle, especially in those with 2 follicles, the pregnancy rate in the subsequent cycle was higher. However, they did not conclude this being the better option because less than 50% of the patients came back for the treatment. So there was a huge loss of follow-up to treatment, and therefore the overall pregnancy rate diminished in the group that abandoned the treatment. So again, this third group, why did they decide not to go ahead, or why did they decide to go to IVF? Because of the perceived potential, poor potential outcome, and a perceived better future outcome, and the financial burden, of course. So this study concluded by saying that our data suggests that for such poor responders, proceeding to vaginal egg collection may represent the best chance of a successful outcome. So I think the studies are now concluding quite clearly. About 7-8 years ago, while I was training in guys, it was very clear, 2 or less follicles, don't go ahead. See whether the tubes are open, how's the sperm, do an IUI. And I don't think any of those ladies got pregnant. So now we need to rethink on those terms and decide what to do next. I did a quick retrospective analysis on our data and the last 50 cycles with 2 or less, and there's a significantly good pregnancy rate going on. So this is not a concluding study. There's a huge heterogeneity in this group, the BMI, the age, the FSH. But if we go only with the follicles, going ahead with egg collection is perhaps not so bad an option. So finally, I would like to conclude by saying that IVF, rather than converting to IUI, is a better outcome in poor responders. Like in most studies, we need further large randomized controlled trials. Thank you.